Hello, everybody, and my apologies for doing this virtually. I'm currently at Boston, and I'm very thankful to Dr. Honavar and the Agenda Pharma team for having me take this lecture despite being present virtually. I'm Tarjani Dave, and I'm going to talk to you on current trends in socket surgeries. I have no financial disclosures to make, and I'm going to make this presentation on these 5 objectives. I'm going to speak to you about the ideal socket, the ideal surgeries, the ideal cosmetic outcome that you should be expecting, certain complications very briefly, and then eventually summarize it for you. So let's get started. What is an ideal socket? For me, an ideal socket is the one where you've correctly identified the pathology in the patient, say for example a thysis bulbi, done an appropriate surgery, say an evisceration and implant, given a good cosmetic outcome with a matching superior sulcus and a nicely crafted prosthetic eye that leaves the patient going back happily. This, in my opinion, is the most important thing. So to have an ideal socket, let's look at the ideal surgeries that we have in our armamentarium. Whenever you are faced with a suspected or a proven intraocular tumor, it is mandatory and prudent to go ahead with an enucleation and implant. But in all other situations of a end-stage eye, an evisceration is much less destructive and possibly becomes the surgery of choice. We are going to focus only on these 2 surgeries for today's lecture. We've looked at the type of surgeries, but what I also want to cover under the ideal surgeries is the technique, the implant, and the post-operative care, which in my opinion are very important. So first, looking at enucleation, we've moved on from performing an enucleation where the extraocular muscles were not preserved to an enucleation which is known as myoconjunctival enucleation. Now, this is a busy slide, but let me just take you through the collage of pictures. You begin by performing a peritomy and a Tenon's dissection in the 4 oblique quadrants, and then you start identifying the horizontal recti muscle. So the medial rectus here has been tagged with a 4O silk, and about 6 to 8 millimeters from the silk, another vicral suture is passed through the muscle, and eventually the muscle is cut between these 2 sutures. So what happens is at the end of tagging the 4 muscles, you'll have these 4 silk sutures to give you traction, and you'll have the 4 vicral sutures which serve the purpose of enhancing motility that I'll shortly get to. Once you've enucleated the eyeball, you go ahead and identify the central cavity and put your implant right in the center. These small globules of intraconal fat allow you to identify the central space correctly, and then a closure is done of the posterior tenons. Once the posterior tenons has been closed, remember the 4 vicral sutures that carried the 4 extraocular muscles, those sutures are brought out into the 4 fornices respectively. And what these sutures do is they support the muscles and bring them towards the fornices, and therefore whenever the muscle moves, the prosthesis which lies right in front of it and rests in the fornices also moves, and this helps in improving the motility in patients with enucleation. For evisceration, nearly everyone in the plastics community has moved ahead to perform an evisceration with what is known as one of the techniques of sclerotomies or flaps. And what I like to do in most of my patients is to perform a 2-flap or a 4-flap surgery. The initial process is very similar to an enucleation where you separate the structures, you remove the intraocular contents, and this is the most important panel where you perform a sclerotomy right from the limbus posteriorly and then dissect off the sclera from the optic nerve. So eventually what you have done is you have separated the 4 flaps of the sclera from the optic nerve. You can now place a nice large implant inside and bring the flaps over to cover the implant so that you don't have the risk of implant extrusion and still can place a larger implant, which definitely gives a better cosmesis to these patients. So coming to the types of implants, most of us tend to use the non-porous implants. They do have about 2 to 3% rate of exposure and extrusion and about a 2% rate of migration. But nearly every part of the world non-porous implants are slightly more preferred over the porous implants because it has now been shown that porous implants cannot improve the motility until and unless a second procedure known as pegging is performed, and pegging comes with its own complications. The most important part in socket surgeries is pain control. Evisceration is by far the most painful surgery, and what I like to do in my patients is to inject retrobulbar ropivacaine, which is a long-acting anesthetic, to keep them pain-free. I also admit all these patients and give them IV Merimol. And I'm sure every surgeon here who has performed an evisceration has had an episode where you've discharged the patient, and in the middle of the night you're called with an emergency and excessive pain in the patient. So, coming to the ideal cosmesis in these patients, I assess the socket in terms of surface, volume, prosthesis, and the eyelid. And I'll give you certain examples. Like this is a patient without an implant, and all I have done is placed an implant in a secondary sitting, and you can see the sulcus has built up and it's given a better cosmetic outcome. This is another girl who's very bothered by this sulcus, and what I've done for her is I've harvested fat from her abdomen and transplanted it into the orbit, reducing the enophthalmos and improving the appearance. For those who are very desirous of a quick fix, I inject readily available hyaluronic acid filler into the orbit, and you can see this is pre-injection, post-injection, and you can see that the sulcus beautifully builds up. Though temporary, it gives very gratifying outcomes. And for those that have a significantly enlarged orbit, I like to place a second implant like a porous wedge implant along the floor to build up the volume in the orbit and therefore give a better appearance to the prosthesis, as you can see in these pre and post pictures. Those who have a surface loss, my preferred technique is to perform a mucous membrane graft, or sometimes I also resort to performing a dermis fat graft. And these are examples of patients where I've corrected the volume as well as the surface in the same sitting by performing a secondary implant, fornix formation, and mucous membrane graft. You see the mucous membrane graft taken up here, and you can see that the lower eyelid retraction, superior sulcus, everything improves. The prosthesis weight significantly reduces, and all of these help in giving a better cosmetic outcome. This job of giving a good outcome is incomplete without an excellent ocularist crafting a beautiful prosthesis for these patients. And there's a lot of technology available now to make the prosthesis look as real as possible. And I resort to having the best people do give the best outcome to my patients. The last part is about the eyelids, and many times you would see that everything is done well, but there is a little bit of entropion or a little bit of ptosis. When I see entropion in anophthalmic socket, I like to perform a hard palate mucosal graft where I harvest the graft from the mouth. The site heals beautifully, and I transplant this tissue in the superior and the inferior eyelid as a spacer graft, and you can see the lash ptosis and entropion has improved. Ptosis following socket surgery is very common, and a lot of these patients require a ptosis surgery as a second sitting. Again, I like to perform either a levator resection or a Mueller's muscle conjunctival resection in these patients for correction. I'll just briefly talk you through the complications. Most of the complications that we tend to see are implant exposure and extrusion in a non-porous implant. You also tend to see implant migration, but this is relatively uncommon. All of these require meticulous detection and will require a second surgery for correction. Sometimes in those prosthesis wearers who've been using the prosthesis for a long time, they might come back to you with a complaint that it's now looking proptotic. So if it was a tumor for which you enucleated the eye, think of tumor recurrence. If it was not a tumor, think of a cyst, and you'll see this collection of fluid, which is nothing but an implantation cyst within the orbit. And these are easily amenable to aspirating the fluid and sclerosing the cyst with the help of sclerosants such as sodium tetradecyl sulfate. In summary, I've spoken to you about the ideal socket, the surgical techniques, the implants used, the postoperative care, which is important, ideal cosmesis, which in my opinion revolves around surface, volume, prosthesis, and the overlying eyelids, and I've briefly touched upon the complications of surgery. Thank you so much for a patient listening.
Thank you, Tarjani.